Some of the additional challenges that we came across when we were talking with stakeholders. For dietitians, it's becoming difficult to find work in the rural setting, and there are wage gaps between hospitals and family health teams. With mental health services, generally a gap in child services. With pharmacists, it's mostly part-time work, and again, it can be difficult when they're being attracted by the money they can make in the private sector. Med lab technologists, it's mostly part-time, and it's challenging to recruit good applicants. Same thing with social workers. We were informed it was difficult to recruit social workers. Directors of care, limited pool of qualified workers, high level of responsibility and stress, limited remuneration, so a lot of disincentives to take on those positions, so hard to recruit for. And same thing with executive directors, hard to recruit for. I talked about volunteers being a growing and an important sector that we need to look at in terms of their role with the health sector. They're an aging group, particularly with the long-term care facilities and retirement homes. And there's the stakeholders associated with those organizations recognize that something needs to be done to ensure that they've got that next crop coming on. So we did look a little bit at the training as part. So many of the organizations that we spoke with are offering some degree of professional development. They recognize in some cases, though, they are restricted by the amount that they can offer based on the annual budget they've got. So they recognize that staff would actually like to have access to more PD opportunities, but there might be a line item in the budget that restricts that from happening. So we've got a recommendation later around in terms of pooling resources, identifying where there might be some consistencies or similarities with the type of PD that can be offered, and maybe looking at collaborating with other organizations to enable that to happen. We looked at MedQuest, we looked at the Rural Work Placement Program, and HealthKick partnership with Georgian College for the PN program, the Practical Nursing Program, and the Food Service Worker. So training's being offered locally through those organizations. We did a survey of recent graduates out of those programs as well to get a sense of their satisfaction, what they're doing now, even their attraction to, after taking the training, would they be willing to, or are they still interested in coming back to a rural area like here in Perth to actually practice if they can find a position here. So in terms of conclusions and recommendations, so as we mentioned, it's a very rural population, it's an aging population. We see it driving a demand for health services in the coming years. We also know that there are people leaving the workforce here in terms of looking for opportunities elsewhere. There's a recruitment sort of horizon coming up for doctors and nurses that's going to be a problem. Physicians also represent an intergenerational workforce in that more recent graduates are tending to reduce their workload and seeing fewer patients. So we can't just be recruiting for a one-on-one replacement. It's going to have to be 1 to 1.5, 1 point, or 2 even, to replace every doctor that's leaving the field now, right? It can't just be a one-to-one replacement. Nurses also nearing retirements, but other problems also that are plaguing that. In terms of lack of full-time positions, there's the wage discrepancy between settings. Leadership training, we were informed, is lacking in the LTC setting, so that's not being offered in the training institutions. And it's not being promoted. Positions in LTCs, nursing positions in LTCs, really is not being promoted or encouraged in the LTC settings from what we were hearing. And NPs are increasingly playing a key role, although it can be challenging establishing themselves. And to some extent, NPs prefer to work in partnership with another NP for that workforce support. Succession planning for senior management positions is key. In some cases, we noted that for family health teams, for example, the EEs that are in place have been there for quite a while, and thought needs to be put into who's going to be the next person to come in and fill those shoes. The job description has probably changed since that person was first hired for that position. So moving on then to our recommendations. We came up with 6 recommendations that we think can be acted on locally, and another 4 or 5 that we think are sort of higher up level for the government, provincial government and other organizations. So beginning with the first one, identifying health human resource professional development needs across organizations. Are there opportunities for sharing PD activities And is it possible to coordinate resources to enhance the feasibility and accessibility to those PD opportunities? We're recommending that we've got a rural recruitment strategy in place, but we need to put in place a rural retention strategy to go along with it as well. So looking at what we can do around management, wages, pull factors to ensure that people, that the healthcare resources are staying in the communities where they first settled. Developing a rural volunteer strategy, as I talked about before, in terms of ensuring that we've got that next crop to come up and replace the ones that are sort of, in many cases, the older volunteers that are close to being a client themselves in some of the long-term care facilities and retirement homes. Developing succession plans for senior management at family health teams and other organizations. Conducting, ultimately, a more in-depth review of the non-regular professions and the self-employed workers out there. Again, we think we scratched the surface on this. We've got a feel for it. It's a large workforce, but we need to continue the work on developing a systematic approach to collecting current data for that group. It might be a matter of bringing in other organizations like the HealthKick, for example, which does an annual, it has a reference list that it creates every year, and perhaps in the process of updating that list, it could reach out to the non-regular professions, self-employed group, to get a sense of what their employment numbers look like and the challenges that they're experiencing. And of course, our final recommendation is around continuing to support MedQuest, the Rural Work Placement Program and local training opportunities. MedQuest and the Rural Work Placement Program are really effective in a way, especially the Rural Work Placement pieces, recruitment strategies for many organizations when they can bring that person into their environment and they get a sense of what it's like working here. MedQuest, of course, is getting them when they're young, introducing them to a health career in the rural sector, in the rural setting here in Huron and Perth. In terms of future directions, so some of the higher level recommendations that came up that speak to what we think should be put on the Ministry of Long-Term Care Health and MTCU and so on. We feel there's a need to adjust policy and provide funding to support assistant positions for directors of care in LTCs. We'd like the Ministry to review the role of the RNs, RPNs, and PSWs to determine where scopes of practice can potentially be expanded. And with the Ministry of Long-Term Care and MTCU, the Ministry of Training, Colleges, Universities, encourage training institutions to promote career opportunities in long-term care facilities, and collaborate in marketing and promoting nursing career opportunities in other parts of the rural area in general. Right? There's just opportunities in rural areas. Need to ensure that the courses that the training institutions are providing, again, are providing orientation to practice of nursing in rural communities and promoting clinical placements in rural communities. What is missing, though, what still needs to be followed up on, is when we get we'll update the report with the 2010 data. So the report as it is now, we can go back in there once we've got the 2010 data and update those figures. We still feel there needs to be an update or an in-depth review of the self-employed healthcare professions and more further research on the non-regulated professions and other allied healthcare professionals who provide services to the community. In terms of who takes the lead on this going forward, HealthKick, the Service Provider Council, has led this to date, but we need to have a discussion on what group is going to be stepping into this role to ensure that we've got enough data in the current inventory going forward, that we're aware of what the current challenges are, that we're not slipping in terms of responding to the changing demographics in relation to the healthcare workforce. I'd be happy to take questions, and I know that was very rushed. The report itself is over 100 pages, and I've tried to just sort of gloss over the key findings of it. Happy to take questions though right now. Yeah.
Back in the regulated positions, it says like the limited availability of full-time positions remains a problem. Is that just in rural areas compared to urban areas, or does that happen in urban areas too?
I can just speak to, this is what I can't say for sure that we did sort of follow up on that to see if that was also a trend in the urban areas, but it was part of the finding for the rural part. And I can't
so
speak.
You don't know that?
No. Yeah.
On the intergenerational workforce, you mentioned specifically about physicians and how that's being seen there. Would that not also be an issue issue throughout the workforce. It may not be as obvious, but if you have people that are less willing to work those extra hours without compensation and those sorts of things that I think are happening, there should be as well in other professions that same issue where you're going to have to replace with more people to get the same amount of productivity.
I'd say yes. I mean, the younger workforce coming through now has different expectations around what the balance between life and their work is going to be, right? It's not going to be the 9 to 5, or it's going to be the 9 to 5, or even less if possible. Weekends are going to be open in their calendar as opposed to the work committed. So I agree. It's wider than just the doctors, but it came up in the discussion as doctors being a real worry, given their role in the healthcare sector. Yeah. Any other comments, questions?
One of the things that I didn't hear talked about, that I often hear talked about, is one of the recruitment challenges, and I'll pick on nursing, but it probably crosses professions, is competition for scarce resource. You've got, a small area needing the same, like everybody needs the same resources, and there's not a lot to choose from. But it didn't seem like that got picked up.
It did come up in our discussion. It's probably more discussion in the full report. And I asked about it if there's sort of poaching even happening within the area in terms of how aggressive are other organizations going after these providers.
Yeah.
The thing is, once a full-time position becomes available, the part-timers are always looking at what can you do in terms of what options do you have? If the option is I've got full-time here outside the counter, even within the county if you're lucky, they're going to go for it. So limited loyalty. The key is to find out that full-time position, that financial security and so on, right? And even the attraction of the right working hours and things like that. As soon as that full-time position becomes available, it's hard to work against that. Yeah.
Just following up on that, I think that same issue is discussed a lot in terms of differentials in funding for positions in different areas. So, for example, in the institutional sector, it's much different than the community sector. Same funding for same positions. So what that means is that it's very difficult for community sector, and I'm just picking on that as one example, to maintain people, because as soon as there's an opportunity in the institutional sector, that's where people go because their wages are better. Now, that's not always true, but there is a bit of a trend. So I'm thinking in terms of recommendations to government, that's a serious issue. It's not something that individual organizations can do. I mean, you can do some, but it does relate to the overall funding.
Yeah. It's the leveling the playing field in terms of at least giving these organizations the wage part is being looked after. What else can we do now in terms of a pull factor to pull them to our setting versus a hospital setting or any other setting like that, right? Yeah.
Excellent presentation. Thank you, Brian Tibbett with HealthForce Ontario. One is I'll carry back that message of the data needing to be updated, pursue that to help support you. One of the things as well, and I'm not a spokesperson for SWOMEN, South West Ontario Medical Education Network, and I know they do work with Huron Perth quite closely. One of the challenges we've got is finding doctors that are willing to volunteer their time to participate in residents coming in and medical graduates coming in and having that experience in a rural setting. We're finding that a high percentage of those that have had that experience tend to return or stay in the community where they've had that work experience. So finding physicians that are willing to volunteer their time is a challenge with regards to having new grads decide to settle in the community.
One of the issues you added was the development of the rural volunteer strategy that you said was not one of your initial issues. And I'm familiar with some of the issues. But can you give us a bit more detail about what you found?
It first came up just with the LTCs and the retirement homes, and it was basically that they just blunt saying in a discussion, what happens if you lose 25% of that force? And it impacts programming. A lot of the day-to-day programming is gone without that workforce, right? So it is serious, and we can't take it for granted. And there's a heavy reliance on an aging volunteer workforce in those settings. They are doing what they can in terms of getting some of the younger people to volunteer in those settings, but it's not the sexiest type of volunteer activity that's
You
going
could
to
make it
attract.
that way.
Yeah, it's just not appealing. It's not seen as being very appealing work, volunteering in that type of setting. And I think we need to sort of change people's minds around those types of opportunities and how rewarding that experience can be, working with that part of the population as a volunteer experience. And I think we need to do something, we need to look harder at turning them onto it, but also when they're in that setting, making sure that they don't feel this is a one-off, right? I'm going to do my 40 hours. I have no sort of commitment or loyalty to come back here because there's no sort of support provided in that environment that I feel that I'm part of a team as opposed to working in isolation, right? So it's and ensuring that when you're going in there, as part of your screening process, identifying what the interests of the volunteer are, so you're matching up activities, day-to-day activities for them that are meaningful to them, as opposed to just being, well, no one else wants to do this task, so whoever sort of gets that volunteer position today is going to be taking that on.
And was there any data that you developed or found?
Not in terms of hard numbers, so we don't have, and that's what I'm saying, I think we need to have a look at what is that, how big is that labor, how big is that volunteer force, what are the hours, what is the dollar value associated with that, so what are the real meaningful parts that we can talk about, the actual contribution associated with that, and what do we stand to lose if we continue to ignore it, right? In terms of both quality of care and loss of experience, meaningful experience for the younger in terms of this might be their entryway into healthcare, right? This is the thing that gets them motivated and starts them down the path of taking a serious look at health, at a healthcare profession.
One last question.
Did you look at all at technology as a support to the provision of services or the lack of?
It came up, but we didn't go down that path, right? So it wasn't something that we put resources into. Because I remember we were talking about, even for example with some organizations, IT support. Do they have enough in-house stuff? Because it could be the bottleneck, right? That is interfering with the rest of their activities and their ability to operate effectively and efficiently. That they rely on either external resources or it's kind of, well, we just, whoever sort of has a glitch that day will look after whatever IT problem we've got, right? Instead of having some sort of a dedicated resource person to look after it. And it comes down to, in many cases, the budget doesn't have a line item for that, right? So we have to look after it internally somehow. Either someone we hire has some skill sets that are wearing that hat that we assign to that type of task.
Thank you, Don.
Thank you.
The next slot will be Laura's presentation, but I just wanted to remind you that you have a pink sheet on your table that summarizes the 6 recommendations that Don listed. And we will be referring to those in the group work after the coffee break. So I'll now let Laura tell us a little bit about the work of HealthKick and the future scenarios from there.
Just to kind of give you a little bit of background, there's a number of people in here who are very familiar with what HealthKick is and what it has done. But we realized that there probably, with part of the discussion being about what use we make of the HealthKick project and that resource, we thought it might be timely to give you a little bit of background. So I'm going to do my very best. I'm very passionate about this, so I'm going to do my very best to control myself and keep it fairly specific, okay? So they may have to jump on me and tear me off here, but anyway. So, I'll do it this way, so the timings are heavily messed up. Just to kind of give you you a sense of what HealthKick has been all about. We started out with a desire to kind of support what this saying has been used by so many for human resources supports. And that is the need to have the right resources at the right time in order to provide the right services. It's very difficult in a human-based industry, though, to make that happen, because human resources aren't something you can order up and have delivered just in time, such as in the manufacturing industry. So it does require a certain amount of forward planning and investigation, and an awful lot of work is involved in the human resources sector. So what we decided to look at was developing a strategy that was focused on a rural environment with an identification and addressing those issues that are predominantly focused on as a rural disadvantage, and also using those advantages that we had to strengthen it. We wanted to create something that had the ability for us to attract youth, because we wanted to have a philosophy of growing our own. We also wanted to have a training-based addressing, because we knew that, especially in Huron County where this started, there wasn't any kind of training related to the healthcare sector locally driven. So we wanted to make sure there was access to that kind of localized training, both for the current workforce as well as those who might be attracted to the workforce. We wanted to support the development of a training culture and support that in having people become mentors and trainers and those kinds of things. And we wanted to also support the recruitment and retention types of activities that were already engaged, or how we could do them not as individual organizations, but how we could collaborate and strengthen those on an area-wide basis. So the whole emphasis for us in making sure that this was going to be successful was the partnership. It had to be partnerships that drove this, because it's very limited in the resources that we actually put into our own human resources into the project itself. So we had to make sure we had partnerships across education, across the healthcare sector, and within the recruitment and retention activities that were actually being conducted. And we did a fairly good job, I think, in reaching out and having those established over the course of the last 6 years. The rollout of the project basically took us, it started in 2005, and at that time it was focused basically as a pilot project within Huron County to develop the model and identify any of those issues that we could modify to take it forward beyond that. Originally it was 2005 to 2008, and then it was extended to 2009 in order to complete our nursing program. The second phase, we gained additional funding to take it from 2008 until the end of December this year. And what that mandate underneath that area of funding was around giving the opportunity to have other counties outside of Huron County have the opportunity to participate in the program that we had developed, to see what fit and get feedback from those groups as far as whether it fit or whether there was interest in it. And just share. We were just sharing the model. We figured if everybody did this, nobody would be stealing away from each other. You know, everybody could probably have a good chance of fulfilling their own resource needs. So HealthKick is basically set up as 4 major areas that we conducted. One was youth engagement, which was around MedQuest. We also, which we worked with Swoman to deliver. We did Spectrum, which was a locally developed one, educational camp for one-day experiences for local high school students. And we did a career symposium that was across all industrial sectors across Huron and Perth counties. We also did the skill development area, food service worker. All these courses have been basically delivered through Georgia College. However, we also did a registered pharmacy tech program that was locally engaged and made sure that we had local access to that kind of skill development training with Fanshawe College. The Healthcare Experience Center, this is where the medical students coming out and doing the clinical placements, getting that connection to the rural environment, and having them see the opportunity of what a rural practice has to offer them in family medicine, and any other co-ops or clinical places that we could do and link for instance, Ryerson University as well. And anybody who just contacted us out of the blue and said, I am from Huron County, I would like to do a placement, can you help me? We would do that kind of casual type of linkage as well if we could. So why is the initiative important? Well, economic development in the rural communities and healthcare go very much hand in hand. The reason that that's very important is, as you heard, a lot of our employment opportunities in rural communities are offered below the norm as far as wages. And the healthcare sector gives us those opportunities that are more than average. And so the importance of those jobs in our local communities is really, really important. Spending capacity and just even the health and delivery of the services that are needed is really important. So it's from a number of different aspects, healthcare sector is a very important player. The innovation aspect of this particular project, HealthKick, is that it is really innovative, and it's been recognized with a number of both national awards, as well as 2 provincial level awards. And it really benefits the youth, the existing workforce, the employers within the healthcare system, and the communities as a whole. And working in collaborative types of arrangements is what we're hoping to emphasize and engage people in. The model is really innovative, and because of that, young people are attracted to innovation. So if we're going to attract young people to the area, we want to engage them in activities and things that give them ways that they can explore their own occupational scopes and give them the opportunities to grow as well in their practices. So the next couple slides just give you some of the faces that have been involved in the project. We've done 6 MedQuest camps and a Spectrum forum as well. We've had over 170 young people. And these people, we still keep in some kind of contact. Not only, this is the starting phase. We see this project as being a continuum of having impact along the career development continuum. So that we start out with them young, at the stage at which they're making some of those critical decisions, and they get some experience and they get some exposure to a variety of different careers. The medical students and the allied health professional students who are looking at wanting to explore rural practice, we've been able to do some of those placements as well. And give them, and often these students actually come back and do some other placements with the physicians, for example, that they have been exposed to. So it's a good development and exposure. And as we develop our own welcoming type of word of mouth is one of the biggest and strongest types of things. If we can provide that kind of an environment for them to learn and experience the profession in a rural environment, this is probably one of the key things. This is our graduating class of 2009, our first practical nursing program that graduated. The top one and the second class is down below. They're on the way. The first class, we gave them all caps, which they don't do anymore, but we decided that was a really good thing to do. And they loved it. They loved it. And not only that, they were special because they were pioneers. They put up with an awful lot of growth and issues as far as moving around, but they got a home and given them the training facilities that we currently have are good. They could be better. We could always improve, but they are a good starting base, and they have seen that growth and are extremely supportive. And actually, I think there's 5 of them who are going on and now currently doing their RN on a part-time basis as well. So it's that lifelong learning that we've instilled in them. They've worked hard for it. Food service worker program is another one that was in demand, identified not through the long-term care facilities because of regulation changes, that we needed to meet that localized demand. We were able to work with Georgian College in order to meet that demand and put it on in a fairly timely way. We had 1 graduate class, and we're working on our next. The rural work placements, this is one of my favorites. This is where we have students who've moved on from MedQuest. They've now made that decision and commitment that they're going to pursue a healthcare career. They're from our local areas. We now get the opportunity to entice them to come back and practice, and they establish those relationships with the employers that they work with. Last year we had over 150 students who were applying for these jobs. We had 24 jobs that were actually posted across here in Perth, Great Bruce. And the feedback from both the students and the employers who are engaged in these processes find it numerous advantages and benefits. Primarily, students are getting skill sets and skill exposure within an occupational field that they are wanting to pursue, and they're getting that they wouldn't get necessarily in their school environment. They're also getting that relationship with an employer who is potentially interested in, and the employers are getting access to a pool of students who are highly skilled and know what they want to do, and they're helping to provide that information and guidance for their career development. So it's really, really quite a win-win situation on both sides of the table. Community engagement, that's what this is all about. Today is what we call our community engagement role that we take. And that is where we've been able to support and provide those kinds of maybe coordination types of roles where we take minutes, we send them out, we tell people come to the meeting, things like that. But it's bigger than that. It's that relationship that we hope we've built with the healthcare community and the human resources committee is an example of that, where we try to work together to make a difference as far as coordinated activities that make Huron and Perth counties a desirable place to live and work. And so those kinds of things that we've done we've been able to provide some of the dollars to go into that, but also some of the workforce of that committee to help support that field. The economic impact, we started to look at exactly what are the dollars and cents value of this project, and just from the standpoint of the students who are graduating and the difference that their incomes are likely making to them and to their communities. So going back to that economic development linkage, it's just as an example, you can read the figures for yourself, but what is really interesting is that the graduating class of nurses, we surveyed them and they told us that their top wage that they earned before they started and the bottom wage at which they started, okay, the top of which they left their occupation, their old occupation, and the wage they started when they started as an RPN, on average at least $5 an hour difference. And that's okay for right now, that's impressive, but just think of the earning potential those people now have and the potential. As I said, 5 of those 20 people that we know of now are actually pursuing an additional level of qualification. So that increases their qualification, and they never would have made that jump if they hadn't taken that first step, and it never would have happened if it hadn't been available locally. Our steering committee has been working very diligently over the course of the last couple of months to look at what future opportunities we see for HealthKick and where we would like to see it go. And the timing of this is fairly comparable or complementary. We wanted to see an opportunity for the healthcare community to shape our future, to have an impact on where we go. And we wanted to involve HealthKick to meet the needs of the challenges in rural healthcare human resources by utilizing the best pieces of what the program and the experiences that we have had have to offer. What do we want to keep? We want to respond to the needs of the healthcare community in ways that support their mandates, not drive them. So during 2012, HealthKick will develop a sustainability plan. That will be the next year. That's our next step, which will explore the options to continue the operations while the base of any activities, those program areas that I talked about, will be based on any funding we have available to directly deliver those. Okay. The sustainability planning will require the involvement of the healthcare sector in that process in order to form partnerships that are so key to this. So a continued drive around the partnerships is going to be extremely important. And the level of participation and commitment and involvement will actually determine the level of HealthKick mandated activities. So what we can do will depend on what partnerships we're able to actually form on a solid basis. So the priority areas that the HealthKick Steering Committee has brought forward is training and the development of a localized training site for healthcare. Career exploration, which includes MedQuest types of activities for sure. The healthcare rural work placements, the human resources research and data maintenance piece, if that is what needs to happen, and the healthcare human resources coordination. And that we couldn't come up with a better name than that. Basically, that needs to continue to work with Human Resources Committee, Providers Council, in whatever capacity those groups see us being able to work and support. So we couldn't come up with a really good name for that. That's basically what we're seeing. These are the things that, when I thought about HealthKick and about what we've done over the course of the last 6 years, these are the kind of words that came to mind. And I got a real laugh when I said that I wasn't an instigator. But in some cases, I am, or we are. And it's kind of those things that reflect what I hope we will continue to have in the future. So no one else has HealthKick. This is a resource. This is a gift that we have in here in Perth that we need to decide what it is we want to do with it. And part of this day will help us determine what it is you see is going to happen with it. And this is basically the opportunity, or the very first opportunity, to help us get some kind of indication as far as what you see happening.
So, identify specific required training workshop needs of organizations, something worth doing more. Addresses improvements in healthcare delivery, recognition event. I'm not sure if recognition event is today, or if it's something that needs to be done.
It's another.
It's another
something
thing.
else.
Thank you. Local training for local people, training locally. And this one comes up again later on, so that's an interesting one. Examples of actions or next steps. These all have to do with a central database to access regional education programs, inventory online. HealthKit could make inventory and catalog or promote availability opportunities. This one comes up many times. Online, updated, big job. This group has to do with education, a proposal for the integration of community of education delivery. HealthKit could research the best way to develop professional development to different age groups and professions. This differentiation by age group professions comes up several times. Lunch and Learns by webcam, available to multiple sites. I've been working with telemedicine in Aboriginal Ontario, and they have an incredible video collection so that a nurse gives a specific talk and it's documented, so lots of that. Professional development, use of technology. Again, technology comes up several times as something to expand on. Lobby government comes up as, lobby and advocacy comes up many times. And this one I wasn't sure I understood. Investigate training opportunities in IV insertions, food service workers, PSWs, resident assessment indicator training, health information specialists. Can this group help me understand this? Is it find out what training opportunities are already available in all of these areas?
Those were things that we identified as opportunities for training that we can see coming forward that really needs to happen in healthcare. So we just thought maybe HealthKick could investigate providing those opportunities. Okay. I know IV insertions is definitely one that HealthKick brings forward, but just things that we notice could be brought locally.
Super.
So just ideas.
Yeah,
I
thanks.
think the other part was anticipate. We tend to be good reactors, but not anticipating what things are coming down. The BSCS is coming down with $40 million. You know you're going to need nurses. That'll bring more folks to the area. You know you need it from a service perspective. So why don't jump on it and get it right now?
Right. Great. I added anticipate. I remember when my son played soccer, that's one of the things parents used to scream at and say, anticipate. Yeah, like how, right? fair enough. All right, red cards. Red cards not as in soccer, but issues that are not, that we need to work on more. Professional development, funding, displacement of staff while colleagues are obtaining training. Very practical issue. What is needed? Coordinated leadership development strategy, more locally offered, so I put local again. Promote broad selection in healthcare careers, so open up the menu. Leadership training for healthcare professionals. Need for coordinated mentorship, that came up later as well. I thought that was very interesting. And identifying and supporting informational technology needs. Again, technology came up a couple of times. Issues that are generic, broad, different, recognition of senior practitioners with added skills, expertise, who are experts in their field, especially RNs in DB, emergency, etc. I'm not sure what DB is, but I'm not a medical.
OB? OB.
OB, okay, that I know. Need for government funding for mentorship type programs to capitalize on experienced workers' knowledge, allowing reduced physical workload. So the mentorship part again. Professional development, displacement of staff while colleagues are away training. I think that belongs to that. Ministries do not work together. I put that because that's an observation that's true. Advocate to increase professional development funds in rural communities due to travel and accommodation. Travel came up several times as well. Wage structure discrepancies, e.g. hospital versus community. Identifying challenges, best practices with staff sharing arrangements. There's another one on staff sharing arrangements. And sites and or video conferencing capability. So these are generic ones. So technology is one issue that came up several times. Strong focus on retention strategies for mid-career health professionals. So recognition of what you've been doing. Retention strategies, huge issue. What traction can you get on such a large issue? So here's a very interesting celebration of what you've done, but a challenge. Ability to retain staff through supports. So very important part on that. Distributive medical education. And here I wasn't sure if it was the same as training locally, distributed locally. Does anybody want to comment on that? Can't remember. It's not very clear to me on its own. Does distributed medical education, is it more online?
The bigger strategy is to have education, not just in the city, such as London at UWO, but distribute that education and the students to rural areas. Yeah, distributed medical education. And so part of that strategy is to train, for instance, physicians in the rural communities where hopefully they'll stay or return to practice.
Yeah. I worked in Colombia in South America, and doctors had to do 1 year of rural medicine. Boy, did they learn. That's all for greens. Then lots of yellows here. This bunch was to do with HealthKick, a voice for retention. Question, if HealthKick can really make can HealthKick really make a difference? So here's a challenge. Retention is so key. You are a voice for that. But are you enough? Develop a strategy for retention for different life stages. Strategy to address generational differences in the workplace. I thought this was interesting, this segmentation. Rural hospital RNs education needs to start up again. I think this sequence came from the same group. More local training, local again. Educate high school guidance counselors. I thought that was very what was that all about? It's a problem. Okay. Communicate great stories, always useful. Expand program offerings. When you saw the pictures of all those graduates, I thought you must have stories. Going over here, collaboration of organizations to share staff for full-time positions. I thought that was interesting. Does that mean the full-time person now is busier?
I would think that means that you might work part-time in a long-term care facility, part-time in the hospital, and collectively you have a benefit package.
Oh,
and
isn't that great?
you have that full-time.
Fair enough. Coordination of local professional development events. That's not the same thing. I had them close together, but I think they're separate. Colleges and universities need to get connected with rural Ontario. Okay. They didn't come. So how do we get them here? Creating an attractive community package. Childcare, school, recreation, culture. I think this has to do with retention. Continuation of local programs. So this is continuation of things that are already working. Continuation of new grad initiative. Two other ones here. A union discussion, allowing new grads opportunity for full-time positions. Can somebody illuminate me on this? Yeah, are there union rules against new grads?
Yeah, right now, most people start into the workforce as a part-time person, and when a job is posted, it's the more senior people that get the job. So if a new grad, we may mentor them through a 6-month mentorship period, but then we can't offer them a full-time job because someone more senior, if there is a job that's going to be available, someone more senior is going to take it. And is there some way of working out a strategy where maybe every second or third job or something that will become available would be offered to a new grad as opposed to a more seasoned?
All right. This one, role for HealthKick, further development of rural mentorship inventory. So it's not a volunteer inventory, but a mentorship inventory. Neat one. Red cards for this one. Advocate for recruitment initiatives for other healthcare sectors. So the advocacy point keeps on coming up. But this is recruitment initiatives for other healthcare sectors, like what is in place for doctor recruitment initiatives provided by ministry. Needs for physician recruitment in particular across other health professions. I think that was mentioned in the report as well. Share the care model to help with family care issues. Can somebody tell me more about share the care model?
That was, I brought that up. It was tying in with what we're doing with another program to help families and friends look after people that are ill or whatever. We thought using something similar like that. So when we have staff that would be able to come to work if there was somebody in an emergency situation to provide care, child care.
Okay. Okay, interesting, thank you. Winter driving, cost of gas detrimental to rural health care. Workers, is there improvements possible? Carpooling, I don't know, but put a car there beside. Market mature living as an industry. They've done that in Northern Ontario, right? Lack of full-time positions after new grad nurse completes a program with the employer. Local physicians to train potential students. How? Is there an example?
Again, we were talking about the mentorship program and to bring some of the student physicians out to rural areas. There's a shortage of physicians that are willing to take on that mentorship role.
Right. Okay. Other ones, what can technology do for rural health care? So technology keeps on coming up. Reference to local students for university preference to local students for university programs. Somebody lost a lot of volunteers. Is that what I'm understanding here?
Yes, that's mine.
Okay.
Yeah, over the summer, we had a number of volunteers that actually retire and die, and we're a community support agency, so without volunteers, we can't operate any of our programs. So we had a number of volunteers, and of course, you have 2 new ones start. It really doesn't do the replacement issue. And I was telling the ones at our table a few years ago, our oldest volunteer was 93. Yeah. And we have volunteers that are also our clients, so it's a huge, huge issue.
Yeah. And in this same group, somebody said, put a dollar figure on the value of volunteers. It's like we're leaning on them so much.
Well, we do in the community sector, we just attribute, it's not a huge dollar value, it's like $12.50 per hour, which it has increased somewhat, but when you calculate that out, even for a year volunteering community agency, it equals about $60,000+ a year. And where do you get staffing at that commitment as well?
And where did you get that number of 12?
It was a number that was given to us through the South West LHIN that we used for tracking performance.
That's basically a salary for an unskilled person. And you probably have somebody who's very skilled.
Oh, yeah. Skill based.
right.
So really, you're not really judging. Yeah, very much underestimating.
Okay. Volunteers are a key piece of service delivery. Yes. Use HealthLiN as a central location for all things health.
That was ours. So we thought that the use of the healthline.ca website is so unique resource in southwestern Ontario, and it is, that really start pointing, if you need volunteers, if you're hiring, centralize things within the healthline.ca website.
That's a,
Because what was
so this is
identified-
something that HealthKick does not have to replicate then, right?
No, they don't, and what was recognized was volunteers don't know where to go to look for some central place to find jobs to volunteer.
Right. By the way, since I can't see you all, if you have something to say, jump in, because I won't be able to see you.
I want to jump in on the Healthline.
Yep.
That also probably applies to a database around employment, because there is a career section on the Healthline, and the Healthline divides itself up according to county and according to section. So it actually, you can create and maintain a local sort of flavor within that.
Great. Recruitment and training, recognition and appreciation are priority activities, yet few organizations have a dedicated volunteer coordinator. That's very concrete. Continued need for skilled training volunteers to deliver healthcare programs. Okay. Then the yellow cards of next steps. Create database for volunteer opportunities, coordination of education of volunteers, and key contacts could be HealthKick. So again, you need to figure out how you link up with that. Volunteer centralized database, coordinate access for all addresses, needs, different types of organizations. So that part is the whole database issue. Yes, would like to see expansion into volunteer strategy, help organizations make volunteering fun and develop some. Here's a whole bunch of goals and strategies or how-tos. People don't know where to go to volunteer, promote volunteerism, and here it is, healthline.ca. Develop a strategy for recruitment for different life stages, 93-year-olds and focus on Victory Lab students by developing specific tasks, example, teaching computer skills, so they gain a credit by co-op instead of community hours. Credit by co-op instead of community hours. I thought that was interesting. Attracting young volunteers, early introduction to volunteering, part of our culture. You know, my son did Katimovic, and I'm not sure if Katimovic has people working in the health sector, but they're very keen people. Volunteer strategy, include development of culture of giving. Isn't that great? Nurturing the role and experience for retention, valuable supportive experience. So the whole volunteer area, I think, is very, very rich in terms of possible strategies. Here's a different one. Collective seed funding instead of organization by organization. I thought this merited a bit of feedback or more elaboration from whichever group this came from. Collective seed funding instead of organization by organization. Can somebody tell us more? Must have been a moment of inspiration there.
It's gone.
All right.
I know what it was. It was around transportation. For example, at our table there was hospital, community sector, there was a health unit, and so different organizations, healthcare sectors have different mandates who they can serve. So transportation was one issue that was brought up. So of course, if there be like a central pool or something so that it's for the group as a whole and not for per individual agency, that is where that started.
Okay, got it. Thank you. Red cards. Market mature living as an industry. Market mature living as an industry. Somebody was copying here. Making healthcare attractive to volunteers. Best practices guidelines for volunteers in the health sector. I thought that was very concrete. Yeah. Promote through volunteerism when in health careers. No, men. Is that what I'm reading? Promote through volunteerism men in healthcare careers? Was it men? Or am I not reading right?
Yes.
Yeah?
It was better.
Men. I think scope and size of volunteer issue means measuring it?
Yes.
Yeah, okay. Market volunteerism with peer-to-peer encounters. I thought that was great. The peer-to-peer makes such a big difference. So like the lava life of volunteering. Hey, there's an idea.
Meet your partner at a I like it.
Speed dating at the retirement home. Okay.
You'll have the residents wanting to
That's right. That's right. All right. Now, issues that were not already covered. Wider issues. Dilemma of volunteers in unionized environments. Same challenge as volunteers' legislated requirements. Police checks. Yes, I know that's an issue. HealthKick should not be in the business of volunteer evaluation. The system is too complex for one organization to evaluate. So you're not alone. So whoever wrote this, call Laura and tell her you want to help her out. But I think volunteer evaluation is a very interesting area. Just to figure out not only the numbers of what they contribute, but the quality. So here's something you don't have to worry about. Not alone anyway. Advocate regional or local provincial marketing strategies to promote volunteerism. So here's an advocacy one. Existing volunteers who want only specific tasks to do. That's just an issue that I guess comes up.
I think it's a timing issue. It's the age of the people. It's a generational issue too.
Uh-huh.
I'll do this for you, but I don't want to be a volunteer for life.
Yeah.
And that's the change that we need to conceptualize.
Right. But they may get hooked, right?
They could, or they
Yeah.
could expand what they'll do. I'll do this event, and then it becomes, I'll look after this whole event for you.
Yeah, yeah,
So-
sure. And that has to do with recognition as well. Aging population, another issue to do with volunteerism, and putting a dollar value on volunteering, which we already covered. By the way, $12.50 an hour, I'm on a volunteer board, and our funder prices the volunteer hour at $25 an hour. That's our in-kind. So, but we're volunteers too. Issues that are endorsed, lack of succession planning, many leaders approaching retirement. Dawn told us about that as well. Senior managers need to be developed. Development for boards, this is important. I think there are resources around for that. Leadership training for future leaders, identifying future leaders within your organization. So who's there that you can already flag? Provide traveling mentor to offer support to any type of healthcare organization. So this is, I come from agriculture, it's like the extension worker approach. I thought that was very good. Develop an educational module for staff succession planning at the college level. Never thought about that. Mentorship, leadership planning for staff, for senior staff through continuing education. I think that's what it means. So make succession planning something that is taught. Ensure local continuing education includes offering for senior management development. So same issue here. Red cards, need and access to healthcare management courses. Same thing. Funding and time required for training. Somebody mentioned, how do you replace the person who's gone for training? Tuition reimbursement program, local high school grads. Tuition reimbursement. How does that work?
There's for nurses, if they're from a rural community and they sign an agreement to return to that rural community for a return of service of 5 years, their tuition is reimbursed by the Ministry of Health.
Okay.
Brian, do they have to be from the area to return, or can they be from somewhere else going to a rural community?
But they have to be from a rural community, returning to a rural community.
And only certain rural communities
Yeah.
that are designated under service, and that's physicians and nurses, but what's the high school connection? That's what I don't get.
Local high school grads?
Informing them as they return.
If they went to high school within 100 kilometers of the community.
Oh, I saw this.
Of the underserviced community.
And they have to have a rurality, the community has to have a rural index of 40 or greater, which is a density of population distance from a hospital measurement.
Okay.
Nearly all of the communities north of London, except Stratford, Owen Sound, Strathroy, would be eligible.
But within here in Perth, we only have two.
So-
Goddard, Clinton, Seaforth, three.
So this is an existing program that was not covered by this study, but are you suggesting that it be promoted more, replicated more? Just flagging it.
Worthy of knowing.
Worthy of knowing, great.
Yeah, we're finding new grads don't know about it.
Okay,
Grads that go into nursing, they don't know about it. And
Right.
they're from the community, and then
Uh-huh.
we tell them when, during the interview, they go, oh, really? Yeah.
okay.
So, yeah, I don't know where the education comes with that.
I'll just put promote.
We cover part of that when we do MedQuest.
Okay.
We do,
Uh-huh.
but again, the timeline between when they're in MedQuest and when they're actually graduating, things can change in that period of time too, so.
Maybe it needs to happen at the college.
That's what I'm thinking.
Yeah.
Because I mean, I'm from high school, but we can talk in general, but I think the bigger numbers are going to be in the actual program at college.
Sure.
Or university.
Yeah, that's very
Should
important.
be part of the
Great.
program.
Okay, moving on. What's needed? Coordinated leadership development strategy more locally offered. Again, local. Succession planning is responsibility of each organization. Okay. And then management wages, compression factor, frontline staff versus management. I think I understand what this is all about, but I don't think we can solve it right now. It's the contrast between rates, and I think that was mentioned before. Too much focus on family teams, really around leadership and healthcare. Leadership development needed. So leadership, again, mentioned here. Facilitate senior management, networking, collaboration, support opportunities that could be role of healthcare. Oh, facilitate senior management networking, so collaboration among senior management. And that could be a role for healthcare. All right? More in-depth review of self-employed healthcare professions. Yes, with a broad spectrum, physiotherapy assistants to physicians and everything in between. So yes, in general. Examples of other things. I'm not sure I understood this. Go-to place for local program services. Info that is up to date. I think it's the up to date, is to keep it up to date. HealthKick could continue collection of broader data as well as ongoing updating of service provider information. So, continuation of that. Consider this is an interesting one. Consider transferring educational skills of one field to another of need. Example, unemployed paramedics become PSWs. Okay.
Big salary differential.
Equivalency.
Big time.
Yeah. Anyway, it said consider. Fair enough.
The example that we had was that I guess there's 300 paramedics graduating a year from community colleges, and there's not many jobs.
All right.
So,
So maybe we need to be capping some of the numbers that they're allowing to train and increase the numbers of nurses that
And
are training.
The other point was that it's possible that maybe PSWs wasn't the right field, maybe closer to an RPN. That would be a more relevant position switch, that they wouldn't need much bridging
Right.
to end up being RPN.
The idea is just to keep healthcare educated students in healthcare.
Yeah. So that's an example, but there's many variations and issues. Red cards, in-depth review with recommendations for more timely regulation. That follows on what Don mentioned. Educate public on qualified care providers. Does this mean make them aware that some providers are registered and some are not? Is that what that meant? Educate public on qualified care providers. We're not sure. Moving on. Transportation distances is an issue. Big picture blue cards. Don't understand this fully. More clarity needed. Don't see where the issue is. So this group was not convinced. Get in touch with college associations to give info and need of HP area, physio, obstetrics, etc. So this is more the contact with colleges, which was already highlighted that it is happening. Regulatory body, something certificates should do planning. Granting, a regulatory body granting certificates should do planning. Okay. Laura understood. I did not, but that's great. Programs like MedQuest, Rural Healthcare Worker work placement programs. Student work placements in rural communities, yes. Local training being offered. Rural healthcare work placements, excellent. Good, don't lose it. Support and expand rural healthcare placement programs, multi-year programs. Proven success that is trackable. So I think this is also the idea that you can tell stories about that. Definitely continue because our needs are different due to geography, demography, and ethnicity. Issues to work on, continue with current programs and expand. Local training to be continued and expanded. Continue as is, lobby for continued funding. Engage more employers, expand into Gray and Bruce. Continue support of employers by HealthKick. And agree, participation, HealthKick involvement, yes. So a lot of support here. Red cards, ensure that monitoring and follow-up of program participants happens regularly. So long-term follow-up, which would be very interesting. Identify potential recruits, yes. Funding for local training, expand funding to support students ongoing to participate in programs. So I think all is consistent with continuing that and expanding it. Blue issues here, ensure each placement has a mentor, nice. Internal support for placements by existing employees and employer. I think the mentor one is very important. Marketing the rural lifestyle, similar to other marketing examples, but this is the rural lifestyle. How do we get ministries and LHINs involved in healthcare, HR to understand operational issues? How do we get ministry and LHINs involved in healthcare, human resource to understand? Well, by doing what we're doing today, right? But yes, it's like we need to do more of that. Expand PSW to include Alzheimer education, or i.e. GPA Montessori. I don't understand GPA Montessori.
Gentle persuasive approach is a training that we provide to long-term care staff in how to deal with challenging behaviors, responsive behaviors of clients with dementia.
And Montessori?
Montessori, again, is activities that can be done one-on-one with residents. That's how we could instill volunteers on nursing not having the time or the ability to do that one-on-one
Right.
activities with residents to control responsive behavior.
Interesting. Okay. Continued funding and sustainable funding for HealthKick to ensure efforts are spent doing the program rather than fundraising. Don't you like that?
Did you write that?